Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hi, good afternoon. Thank you for joining us for this webinar, which is going to provide hospice professionals best practices regarding coding. With our new regulations around coronavirus, this topic is particularly timely. My name is Laura Barnett, and I'm on the marketing team at Axxess. Before we get started, I'd like to tell you a little bit about Axxess. We're a leading technology company serving organizations that provide healthcare in the home. We offer a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. A couple of housekeeping notes: everyone is on mute, and if you happen to have a question, please submit it through the chat box. If we have time at the end of the webinar, we'll answer those, and if not, we'll follow up with you after the webinar today. Today, you'll hear from hospice expert Nanette Minton. Nanette has been in home care since 1997. She served in a variety of roles, including clinical, administrative, consulting, education, and agency startup and development. Currently, she serves as a senior clinical coding manager for Mac Legacy. Nanette provides day-to-day coding and quality support to the home care and hospice agencies that they serve who are receiving coding services. Also joining her is my friend and colleague, Matt Abbott. Matt is a senior product manager at Axxess. He has a decade of experience as a hospice nurse and director of clinical services at agencies in Illinois and Texas. These days, he's working to help make Axxess Hospice the preferred software platform for hospice organizations around the country. Nanette and Matt, I know you guys have a lot to share today, so take it away.
Good afternoon. Thank you for the opportunity to speak this afternoon. Hope to provide a lot of information and make you a better hospice coder. Briefly, let's talk about our objectives. We want to verbalize increased understanding of hospice coding to support that terminal diagnosis and accurately represent the plan of care and the prognosis. We want to help you identify the importance of understanding how to appropriately code that principal hospice diagnosis, and also to discuss required documentation to support coding the primary diagnosis with accuracy. This can be pretty tricky. There's a lot of information out there regarding coding. A lot of it is geared towards the home care industry. And so our goal today as well is to look at those ICD-10 coding rules and terminology to help you better understand how to apply this to hospice coding.
Awesome. Thanks so much, Nanette. I'm going to start out talking by understanding and identifying the risks surrounding hospice coding and its practice. So we know there has been increased scrutiny across our agencies here in the hospice industry. So the numbers you're seeing here on your slide are from the National Hospice and Palliative Care Organization's facts and figures from 2018. And you can see here that the amount of federal dollars being spent for hospice care, as well as the number of operating hospice agencies across the country, has been increasing year over year for the last several years. So of course, we know with increased spending comes increased scrutiny from the federal government, as well as from state and accrediting bodies. So as hospice agencies, we need to make sure that we can shore up our weaker processes and identify what those are. And one of the key areas that we see hospices needing some additional support on is supporting documentation for the patient's terminal diagnosis as well as prognosis. So we're going to talk about the Comprehensive Error Rate Testing Program, which was established by CMS, the Centers for Medicare and Medicaid Service, to help monitor and report on the accuracy of Medicare fee-for-service payments. The CERT testing program measures the error rate for claims that are submitted to Medicare contractors, or MACs, as a percentage of dollars paid incorrectly. Using the MACs use this program to identify areas of focus for their provider outreach and education. So as they're identifying issues, they can provide information to hospice agencies and education on how to correct these errors. So the way the CERT program works is sort of a three-pronged approach or a three-step process that begins with data collection. So the Medicare administrative contractors will ask for random sampling of claims from an agency and submit ADRs or additional development requests for medical records. They do have an 800 number, 888-779-7477, that agencies can contact for any submission questions that you may have surrounding the ADR submission process. Once the data has been collected, it goes through a review process where the claims are assessed for improper payment. If an improper payment is found, a request for a claim adjustment is going to be submitted, meaning they're going to be adjusting the amount that the agency gets paid on the claim. If there is no error found, then no action is taken on that claim. Finally, after claims have gone through the review process, the findings are reported by the MACs nationwide. They are reporting on 5 different error types, and an error rate of greater than 33% is going to trigger an additional review for the agency. So we'll take a look at some of the numbers surrounding CERT errors that have been found. Again, you can see here, this is all Medicare providers, but we've highlighted the non-hospital-based hospice numbers as well as the hospital-based hospice numbers for you. So you can see the projected number of improper payments that has been reported for hospice as a whole, both in hospital and out of hospital, is very close to $2 billion. And so you can understand why this is an area of concern for Medicare and for the MACs. In the middle of the table here, you can see the percentage of service types with improper payments based on the type of error. So Nanette's going to share with us what those different error types are, but we've highlighted here for you from a coding perspective specifically, greater than 10% of the claims which are reviewed have improper coding as part of the reason why the claim was adjusted. So this is a significant issue that hospices need to pay attention to and make sure that they get the coding correctly so that they can protect the payments that they've earned for the care that they're providing. One of the other items that MACs use are Targeted Probe and Educate. That is used by the MAC for medical review for both home care as well as hospice providers. So the way TPE works is they take a sampling of 20 to 40 claims along with the associated medical record for those claims. During TPE, an agency can have up to 3 rounds of a prepayment probe review with education where needed on any errors that might be found during the review. If an agency is found to be compliant, they are not needed to be reviewed again for at least a year on the selected topic that was for the TPE. However, if high denials continue for an agency, they may be referred up to CMS for further action. The other thing we provided you here as well is the maximum acceptable denial percentages for each of the MACs. So NGS and CGS have a maximum denial percentage rate of 15%, and Palmetto GBA has a maximum denial percentage of 20%. Finally, a little bit of history on the TPE program. Over 400 hospice agencies have already begun the review of process under TPE. Again, specifically, we have seen MACs taking a look at patients with non-cancer diagnoses that have a long length of stay. So they're particularly interested in those patients who are living beyond that 6-month life expectancy of the terminal prognosis. That's a requirement for Medicare hospice eligibility, and specifically surrounding patients with non-cancer diagnoses. Both NGS and CGS have targeted a significant number of hospices with denials in excess of those maximum acceptable percentages, that 15% for those two max. And that's been since October of 2017. And here in Texas, where we're talking to you from today, the Palmetto GBA MAC has begun requesting charts, and that started for TPE last year in February of 2019. So Nanette, over to you to talk about some of those top reasons for denial in a bit more detail.
Sounds good. Thank you, Matt. We're going to talk about inadequate documentation on that terminal prognosis, looking a bit at the what needs to go onto an election statement, the physician narrative, reviewing the face-to-face documentation, and then spending a bit of time on that GIP level of care before we get into the meat of the coding part of our presentation. So looking at the terminal prognosis, this is a top reason for denial, and the main reason is because there's inadequate documentation of the patient's terminal prognosis. Remember, terminal prognosis and terminal diagnosis are not the same thing. You have to look at and understand that you may have a diagnosis, but if the prognosis and the overall decline of the patient's terminal state is not documented, or it's not in the plan of care of how that's affecting the patient, then you could potentially have a problem. You need to have clear documentation of that terminal prognosis, and that if the life expectancy would be 6 months or less, if that disease process were to follow the trajectory. And it needs to have meat as evidenced by, as evidenced by weight loss, as evidenced by the patient was able to walk from the kitchen to the living room and now requires the assistance of a wheelchair, or the patient was wheelchair bound and now is only transferred from bed to chair for meals. So things like that are going to actually give you some information to understand that that diagnosis is affecting that terminal prognosis. So invalid election statement, there's a denial for missing components required by CMS. Briefly, remember the election statement must contain the name of the hospice, the effective date of the election, signature of the patient or the appropriate legal representative, the date of the signature, and it must specify the ability for the patient to determine their attending physician or their desire to choose that attending physician. Most of the time on a physician narrative statement, the denial is for incorrect completion. You want to be sure that on that physician narrative statement, that CTI, I've seen a couple of different ways this has been done. You can have a narrative statement that's a separate document, or you can have it included in your CTI. But you have to make sure that it is actually created by the physician and not other staff. That narrative statement has to have an attestation statement that the narrative was composed by the physician to support a life expectancy of 6 months or less, as identified in COP 418.22. So that gives you the reference there if you need to look that up. So unbelievably, the terminal diagnosis is not actually a required component of that CTI, but the narrative must take into account that principal diagnosis and other conditions that are contributing to the terminal prognosis. So in other words, that narrative shouldn't be canned, it shouldn't be templated. It must really paint a picture of what's happening with that patient and why the patient is appropriate for hospice care. Again, reasonable and medically necessary. The CTI must be done at the beginning of each benefit period and, of course, would be updated with current clinical findings. So face-to-face documentation, denial for not meeting their documentation requirements. It must be signed and dated by the visiting practitioner. are required prior to the start of the third benefit period of the patient of each subsequent period. So remember, when a patient's admitted to hospice, they don't have to have a face-to-face unless they've had hospice previously, unless they are on for a second benefit period, and then heading into that third benefit period, a face-to-face would be required. So if you discharge a patient and they're readmitted, and they're going to be readmitted into the third or later benefit period, then a face-to-face visit would be required. It may be conducted by a non-physician practitioner, but that non-physician practitioner cannot certify that the patient is terminally ill. So you have to make sure that there's a good process for how that non-physician practitioner communicates those findings to that certifying physician. Wrapping this part of the section up, general inpatient level of care, denial for inadequate documentation. So was the general inpatient care reasonable and necessary? That level of care is for someone who requires symptom management that requires the skills of a registered nurse for 24 hours in order to maintain the symptoms and to get those symptoms under control. So they require that round-the-clock care. Now, herein lies the problem. You have a GIP patient who's actively dying, and there's a lot of gray around the fact that they had 2 doses of medicine, but they've not required another dose for 24 hours. Are the symptoms now under control? Do we discharge them? So it can be a real dilemma for the inpatient level of care to make sure that they document the things that are required. The patient requires turning, oral care, helping the family cope with what's happening. So there's a whole lot of things that go into that. So most of those GIP denials are based on the continued billing once the symptoms are under control. So you have to really pay attention to how you're managing those interventions and what things you're employing to maintain in palliative care for that patient. Determining terminal prognosis. I'll turn this back over to Matt to speak to us about this for a bit.
Yeah, thanks, Nanette. So talking about determining terminal prognosis, this is a little bit of science and a little bit of art. And so we'll talk a little bit about both of those sides and how having both of those components is important to making sure that your terminal prognosis is documented correctly. So we know that the hospice benefit was designed to provide palliative care and symptom management for a patient who has a life expectancy of 6 months or less if the disease follows its normal course. And so that language is very specific in the Medicare conditions of participation to make sure that we're evaluating the patient's life expectancy and understanding the disease process and trajectory that they're on based on their past and what we can expect in their future. But Medicare also understands and recognizes that patients also may have multiple diagnoses and needs related to those diagnoses as well. So those other comorbid conditions, those other diagnoses that you might be coding for your patient are going to contribute to the patient's overall prognosis. We also need to remember that patients are individuals and people. We all know, I think probably all of us as hospice practitioners got into hospice care because of that philosophy of individualized care. So patients that have the same or similar chronic diagnoses might have different impacts to their terminal prognosis. So even a patient of the same age with the same birthday and the same list of diagnoses may have different effects and impacts of that list of diagnoses on their overall prognosis. And of course, documentation of the impairments related to the disease process are going to help determine and establish the appropriateness of a patient for hospice care beyond just a list of diagnoses. So I like to ask myself or my staff a question of what happened to the patient, meaning what are the diagnoses that have been assigned to the patient. But the second question is, so what? Why does that particular diagnosis matter to the patient? How is it affecting them? What evidence do we have that the patient's life expectancy is short because they have been diagnosed with this particular illness or series of illnesses? So this part, the LCDs, is more of the science portion of determining a patient's terminal prognosis. So Medicare coverage of hospice care, of course, depends, as Nanette was mentioning, upon that physician certification that an individual has a life expectancy of 6 months or less if that illness is running its normal course. But of course, prognostication can be challenging. It's challenging for us as practitioners, and it's also challenging for Medicare administrative contractors and regulatory bodies who are auditing documentation as well. So the Medicare administrative contractors developed local coverage determinations, or LCDs, which are medical criteria for determining a patient's prognosis for those non-cancer diagnoses specifically. Now, of course, there's not an LCD for every diagnosis under the sun, but they have, quite a few LCDs available for those various diagnoses. The other portion here is that some patients might not check all of the boxes on that LCD checklist. However, those patients can still be appropriate for hospice care because of either other comorbidities, because of rapid decline, or again, because of that so what question, how that diagnosis is affecting the patient's overall condition is going to be the most appropriate thing to look at, as well as the LCDs. So again, we have the marrying of art and science. So let's talk about some contributing signs and symptoms for a few disease processes that you might assess for and make sure that they're included in your documentation. So if you're looking at your congestive heart failure patients, some contributing signs and symptoms you might look for are things like edema, muscle weakness, shortness of breath, and pulmonary embolisms that either don't require continued intervention, or perhaps the risks of further treatment of those conditions are going to outweigh the benefits for the patient and might put the patient more at risk. But more than that, how do those signs and symptoms affect the patient? Is the patient having increased pulmonary edema, which is leading to shortness of breath? Is the edema in their legs decreasing their ability to get up and about? Is their dependence on oxygen causing their muscles to become deconditioned? And how do those things work together to contribute to the patient's prognosis? Similar for your COPD patients and your respiratory conditions. Again, those COPD patients are notorious for having that sawtooth decline where they have exacerbations of their disease process and then seemingly get better, and they go back and forth and they vacillate this way for a long time. So looking at their symptoms, how frequently things like shortness of breath are affecting them, and how those episodes are affecting them over time. And again, because of that shortness of breath or that difficulty with their breathing, how is that deconditioning contributing to their overall life expectancy? Your liver failure patients, things like jaundice increasing or increasing ascites, those abdominal girths affecting the amount of food that they can take in, esophageal varices interrupting their swallowing ability and their overall quality of life. So again, documenting those things and assessing for them, making sure that is part of your documentation is important to making sure that you can show a patient's terminal prognosis. Your dementia and neurologic conditions, talking about gait issues, pain, weight loss due to decreased appetite or other factors, as well as those opportunistic infections that we know are particularly deadly for our dementia patients. And finally, for your strokes or your CVAs, again, how are the effects of that stroke contributing to the patient's overall decline? Did the patient have a stroke, have a repair, and fully recover with therapy? Or did the patient have multiple strokes that left them hemiplegic and they're not able to rehab, and how does that affect their life expectancy as well? And something as simple as gastroenteritis that's causing nausea and vomiting for a patient that's had a stroke and has difficulty swallowing, that can be a particularly large risk for those patients. So something seemingly with two different body systems, gastroenteritis and a stroke, can definitely have some correlation and contribute to the patient's overall prognosis. I want to take just a couple of extra minutes to talk about the dilemma of dementia. It is one of those things that many hospice agencies struggle with, really putting your finger on what is the appropriate diagnosis to code for your patient, and how do I identify that clinically. So we know that dementia unspecified, senile dementia, vascular dementia are not acceptable codes to have as that patient's primary terminal diagnosis. One possible solution for that is the G31.1 code for senile degeneration of the brain, and we have certainly seen an increase in the use of that diagnosis since hospices have had to move away from that more generic dementia unspecified or senile dementia code that was so commonly used before. So as you can see on the slide here, dementia, as we know, is really an umbrella term that it has to do more with a series of symptoms that's associated with a patient's cognitive impairment rather than a specific diagnosis. And that's why Medicare has asked us to be a little bit more specific in understanding what is causing a patient to be demented and how is that diagnosis affecting their life expectancy. So you can see under the umbrella, we have Alzheimer's type, vascular type, dementia with Lewy bodies, and frontotemporal. And then, of course, there's mixed dementias as well. So again, I don't want to get into a detailed conversation, but this is a great handout that's available from the Alzheimer's Association. That's a great, front and back tool that you can utilize with your clinicians to help differentiate the course, presentation, and associated features of each of the different types of dementia, so that as you're going about and doing your assessments on your patients, you can see the associated features and presentation that you're assessing at the bedside and get to the proper dementia diagnosis to ensure that you have the right code on your claims to make sure that you can get paid for the care that you're providing for your patients. Again, it's very crucial. A lot of times as hospice practitioners, we end up at the bedside of an older patient with a type of dementia, and we know that they need hospice services, but we can't put our fingers on it. So solving this dilemma for dementia will really help us provide the hospice care to those patients that we know need it. So I'll turn it back over to Nanette.
Thank you, Matt. I want to take a minute to talk about the International Classification of Functioning. If you're familiar with, documentation and where the MACs are heading, especially with those LCDs, they're replacing a lot of the specific information with information from the International Classification of Functioning. So if you can think about documenting with your patient, not only documenting, but what are you going to be coding? What's primary? What additional diagnoses need to be on that claim? Using standard language, the framework for describing and organizing information on functioning and disability is really the hallmark of the ICF. So how are they functioning now compared to what they were doing 2 months ago? What is their increased level of disability? So, body function, body structures, activity, their participation, disability, looking at those impairments and the negative interaction between that person's health condition and their environment. It can be overwhelming to think through that process, but I encourage you to take even 15 minutes a week to learn a little bit more about the ICF. As we move forward in healthcare and you want to be able to justify the care, using this standard language for your documentation is going to greatly improve that. So I've already mentioned these a little bit, structures and function. You're going to look at nervous system, eyes, ears, related, voice, speech, cardiovascular, digestive, GU, musculoskeletal, neuro and neuromuscular. So if you were to think as a clinician and go down this, level of how I'm documenting on my clinical note for this patient, it could make a huge difference in how your thought process is going to show how these things are affecting the patient. So specifically for hospice care, the ICF does allow for a comprehensive description of an individual's health status and needs. When they come to hospice, they don't come with just one diagnosis. They come with one diagnosis and all their other diagnoses, all the other things that go along with that patient, including their environment, their family, their social situation, that's going to affect or potentially affect that outcome. So this allows you to, again, structural and functional impairments and what causes those activity limitations will allow you to greatly increase your documentation and to look at what palliative interventions and care planning can be done. In hospice, sometimes we get away from goals. Home care is very goal-driven. In hospice, I ask you to think through the same thing. If you have talked to the patient, but not asked the family member what the goal is for hospice care, because maybe it's something completely different other than just the obvious pain management and symptom control, really could make a difference in the quality and perceived quality of care that your hospice is providing.
Absolutely, that's so important, Nanette, to make sure that we ask that question. So the last thing we want to talk about before we get into the meat and potatoes of coding specifically is relatedness and coverage of services. So we know relatedness is one of the most complex things that hospices are trying to navigate through, and that challenge is becoming a little bit increased as we look to the addendum that's needed to be added to our election statements coming up in October. So we want to talk just quickly about relatedness and how to determine that and whose responsibility that is, and then we'll get in again to the coding aspects. So the conditions of participation at 418.56 does require that the hospice provide all reasonable and necessary services for the palliation and management of the patient's terminal illness, related conditions, and interventions to manage their pain and symptoms. And a lot of times when this COP is quoted, we stop at management of the terminal illness and we leave off related conditions and the interventions to manage their pain and symptoms. And so we wanted to just highlight that a little bit for you. We know as the years have gone by, Medicare is asking hospices to cover more and more of the patient's care. And it's important also to look at the therapy and interventions that have been determined for the patient on their plan of care and assess those and manage them in terms of providing palliation and comfort without undue symptom burden for the hospice patient. So even those treatments that we're doing for the patient can contribute negative side effects or results of those treatments can be negative for the patient, and we need to be mindful of those things so that we're not creating any undue symptom burden as a result of those treatments. So how do we define relatedness? Dr. Charlotte Paolini says that it's clinically related conditions that are physical or mental conditions related to or caused by either the terminal illness or the medications used to manage the terminal illness. So again, we have both the components of the disease as well as the side effects and outcomes of the medications we're using to manage it. CMS has quite a laundry list of things as far as related conditions are concerned. They define related conditions as those that result directly from the terminal illness, those that result from treatment or medication management of the terminal illness, those conditions which interact with potentially interact with the terminal illness, those which are contributory to the symptom burden of the terminally ill individual, and conditions which are contributory to the prognosis of 6 months or less. They go on to say that they believe, CMS says, we believe that the unique physical condition of each terminally ill individual makes it necessary for decisions to be made on a case-by-case basis, and it is our general view that hospices are required to provide virtually all the care that is needed by terminally ill patients. So as we were going through that list, right, we're starting to check off and think, my goodness, there is really not a lot of things that we're doing for our hospice patients that, according to CMS's own definition, is not going to be related to the treatment of their terminal prognosis. So there really needs to be clear evidence that a condition is unrelated to the terminal prognosis. And if that evidence is not there and not clear, all conditions are considered to be related to that patient's terminal prognosis. So we think about this as we talked earlier about determining that prognosis and how perhaps an infected wound is going to contribute to negative symptoms and the patient's overall decline. And so Medicare is saying you can't, on one hand, document that something's contributing to a patient's life expectancy of 6 months or less and their need to be on your service, but then turn around and say that same thing is not related to their terminal diagnosis and is therefore not covered by the hospice. I included here a copy of the National Hospice and Palliative Care Organization's workflow to help determine the principal or terminal diagnosis for a hospice patient. And again, it's just very evident here. You can see most items are going to fall into the related category when it comes to diagnoses, conditions, and symptoms. So there's basically 3 questions that they have you ask in their algorithm. The first is, are there other diagnoses, conditions, or symptoms caused by or exacerbated by the principal diagnosis? If you answer yes, those diagnoses, conditions, and symptoms are of course related. If not, you move down and ask the next question. Irrespective of the principal hospice diagnosis, are there additional diagnoses, conditions, or symptoms that contribute to the 6-month or less prognosis of the patient? Again, if you answer yes, then those diagnoses, conditions, and symptoms also fall into the related bucket. And finally, the third question is, are there additional diagnoses, conditions, or symptoms caused by or exacerbated by treatment of related conditions? Again, an answer of yes means that those diagnoses, conditions, and symptoms should be marked as related to the patient's terminal diagnosis. Only after you've answered no to those 3 questions will you determine that a diagnosis or condition is not related to the patient's terminal condition. So who is responsible for determining relatedness? So this ultimately falls to the hospice medical director. They have the final decision on determining unrelated diagnoses, but they are going to gather information from clinical documentation, other physicians, as well as the rest of the hospice interdisciplinary group. Again, all of the guidance that we get from CMS is that this relatedness needs to be determined on a patient-by-patient and a case-by-case basis, based on the individualized plan of care. So we know and recognize hospice as person-centered care, and so we have to take that individual into account when we're determining whether a treatment is related. So we can't therefore say diabetes is always unrelated to a patient, or dialysis is always an unrelated treatment that a patient can continue. We need to determine relatedness of diagnoses and treatments and medications on a patient-by-patient and case-by-case basis. And if we determine that there is something that is not related to the patient's terminal condition, we need to make sure that there is clear documentation available in whatever software system you're using to indicate that the rationale is there for the reason the condition is considered not related. So we have a quote here for you that says, "What do I need to know about you as a person to give you the best care possible?" And that gets to what Nanette was speaking to earlier, making sure that we know intimately our patients and the things that are important to them, as well as to their caregivers and loved ones, in order to provide the best care possible and palliate any symptoms that they might be experiencing at the end of their life. Lastly, once determined, those related diagnoses go to the claim. The related diagnoses are used in determination of the management of all covered services, which can include physician visits, emergency department or hospital visits, any procedures or interventions that are performed for the patient, the labs or tests that are done even when those go to determine a patient's prognosis, equipment such as oxygen, hospital beds, and then finally medications. So again, a quick three-step reminder. A hospice physician is going to review all that available information, confer with the attending physician for the patient as well as the hospice interdisciplinary team, and then finally make a determination for relatedness. As I mentioned before, the final financial year 2021 rule is leading to some increased transparency for patients and their decision makers. So CMS finalized in this ruling modifications to the existing hospice election statement content to increase coverage transparency for patients. So as you're determining this relatedness, it needs to be communicated to the patient and their loved ones. So in the rule, Medicare has specified that agencies will be required to provide upon request an addendum listing all unrelated items, drugs, and services, as well as the rationale for that determination to the beneficiary or representative, other providers, and to Medicare contractors. And we know that this has to be produced relatively quickly, so it's important that as you're completing your documentation, you're having the hospice physician documenting this determination and rationale for any unrelated items, drugs, and services. Of course, having this information is going to empower patients to make informed healthcare decisions when they're deciding to elect hospice services. And again, a lot of those items and treatments are going to be considered as related based on Medicare's rationale. And again, the effective date for this ruling is October 1st of 2020. You can go to the CMS website. They have provided some example election statements for you to review there, but just wanted to keep you apprised of the changing regulatory environment that we're going into. So finally, Nanette, I want to turn it over to you to discuss some specifics about hospice coding.
Great, thank you, Matt. I'm going to run through these and give you some basic information, and then we have some scenarios that we want to get to that really puts the all of the rules into real life practice. So for the principal diagnosis code, any coding that's to be done, you're supposed to use the ICD-10 coding guidelines. Now, things have improved greatly, and before, whenever CMS or NHPCO ran reports, there were still many, many hospices that only had one diagnosis on that claim. So now we're seeing, obviously, that change, and multiple diagnoses are listed, which is what's supposed to happen. So thinking about the diagnosis, that principal one should be the one most contributing to the terminal prognosis of the individual. That makes you stop and think a little bit differently about that. And so where, and in the instance where two or more diagnoses equally meet the criteria, then either one may be sequenced first. Now, be sure that this terminal diagnosis or principal main diagnosis, it needs to be the same across the certification of terminal illness, the plan of care, and on your UB04 claim form for Medicare. The primary diagnosis can change, but again, it must be consistent across that, and that the primary on the CTI also needs to meet and match. And if it doesn't, then you need to consider a new CTI. Coding guidelines, again, must be applied through all of this. Remember, and I know Matt talked a little bit about this, but non-reportable principal diagnosis codes, so codes that cannot be used as the principal diagnosis according to coding guidelines or codes with sequencing guidelines. And we call one of those things in the coding world would be a manifestation code. So something that requires, for example, it's due to something else. So maybe you have dementia, but it's due to some other cause, and that other cause must be listed first. Hospice codes that will be returned to the provider for any correction or any Z codes. So while some Z codes are allowed as primary under ICD-10 rules, and for home care, for hospice, no Z code can be primary. You may also not use debility or failure to thrive, which is interesting because there's still a failure to thrive sheet out there talking about that being appropriate. So that's really interesting that that still even exists. And then again, as Matt mentioned, the unspecified dementia. So principal diagnosis, there's been changes noted in these diagnoses. So for example, in 2002, lung cancer was the top principal diagnosis. And then in 2013, you began to move to a debility and adult failure to thrive were the first, and then the sixth most common. So, but effective October 1st, 2014, we can no longer list these. And I understand that. Sometimes, hospices unfortunately began to abuse this a little bit, and rather than really determining the cause of that failure to thrive or the debility or listing it, we're just using that diagnosis. And again, we've seen a flip-flop as hospice has gone on, where non-cancer diagnoses are the principal ones rather than cancer. And so it causes the industry to really stop and look at this as a whole. So changing diagnosis. As your patient progresses through hospice care, occasionally the original principal diagnosis may not be the one most contributing to the decline. So you are able to change those codes at any time, and you would need to document the new diagnosis, the rationale, and if you're not doing it in time with the research, certainly a physician's order for that as well. So other diagnosis codes. The goal is to list the primary and then all other diagnoses identified in the initial and comprehensive assessment, mental health disorders and conditions that affect that plan of care, related or unrelated to the terminal prognosis. So everything needs to be on the claim, whether it's related or unrelated. Resolved conditions should not be reported unless it impacts the plan of care. And diagnosis listing is the responsibility of the hospice medical director and the attending physician. So again, we want to make sure we capture everything. And a lot of times when I'm instructing others on coding or doing hospice coding, I'll use the Z51.5, which is the encounter for palliative care, as a stopping point to determine here are my related hospice, and then below I'll list the unrelated ones. And we'll see that as we move forward in our scenarios. Comorbid versus additional. So you have your primary diagnosis, and then you have secondary diagnosis, which would be defined as conditions that coexist at the time of admission, that develop subsequently, or that affect the treatment received or length of stay. So somehow they're related to that terminal diagnosis. Comorbid condition, rather than a secondary diagnosis, is one that exists at the same time, but independent of the primary. That can be a little confusing, so make sure you're familiar with that. Abnormal findings cannot be coded as a primary diagnosis and really shouldn't be coded unless they're clinical significant, contributes to additional monitoring or diagnostic studies. So let me give you an example. If a patient has chronic low sodium levels, that certainly can contribute to weakness. There's a lot of things that might be going on for the patient, and they currently maybe take medication for that condition. And again, it's showing a decline. Then it would be appropriate to code that not as primary, but to support the other diagnosis. Uncertain diagnosis, or ones that are documented in the record as probable, suspected, likely, questionable, cannot be coded by hospice. And this is true across the board, even for home care. These only can be, interestingly enough, they can be coded by short-term, acute, long-term care, and psych hospitals, but we cannot do that as hospice providers. So general coding guidelines. Codes for signs and symptoms, as opposed to diagnosis, are okay to report when it has not been established or confirmed by the physician, but should not be used as primary. All diagnoses must be stated or confirmed by the physician. I've said that already. And additional signs and symptoms not routinely associated with the disease process should be coded when present. Let me give you an example. As Matt mentioned earlier, one of the signs you're going to see for a congestive heart failure patient under hospice would be edema, routine edema that you see. You would not code edema separately, but you could code, let's say, for example, the patient had generalized anasarca, and that would be a condition not always seen in every congestive heart failure patient, and certainly is contributing to the decline. So you would want to, in that case, include that symptom. The term with or in should be interpreted to mean associated with or due to when it appears in coding guidelines. And so when you see things, and many times when I'm explaining coding to people for hospice, they say, well, it doesn't say that. It didn't say that that was related to this. And you have to understand that according to certain coding rules, the term with or in, we can automatically assume a relationship or that something is due to something else. These guidelines are very strict, and you have to be aware and know what those guidelines are. They change every October or as is needed. So whether you do your coding internally or whether you outsource coding, you want to be sure that you are using someone who's certified in that field to make sure that you're getting the appropriate coding and that you're supporting that plan of care. Problem areas in hospice coding are use of symptom codes, not correctly capturing dementia, incorrect use of combination codes, particularly hypertension and chronic kidney disease and hypertensive heart failure, how you sequence primary and secondary cancers, and really a lack of understanding how to code end-stage liver disease or heart failure. Many people don't know there's actually a code for end-stage heart failure, but usually that code doesn't stand alone, and there's multiple other codes that go with that. And then the use of acute cerebrovascular diagnosis versus sequela or late effect codes, and how that works in the coding world. Before we get into the scenarios, I wanted to speak just briefly to COVID-19 coding implications, because this is going to be around for a while and affect us greatly as we admit patients in the hospice setting who may be suffering or has a comorbidity have been diagnosed with COVID-19. So officially, U07.1 as of April 1st is the code that should be used and should be sequenced first, followed by the appropriate codes for associated manifestations. Even for individuals who are asymptomatic, but who have tested positive for COVID-19, U07.1 is now the code to be assigned. And again, there's multiple manifestations. The one that we have seen most frequently would be the pneumonia, and you would use the J12.89 other viral pneumonia for pneumonia associated with COVID-19. So something to be aware of, particularly if you take care of patients in the inpatient setting or you have inpatient hospice. Be aware also that if you have a documented contact with or suspect exposure to COVID-19, then there is also a code Z20.828 that can be associated with that. So just wanted to be aware, wanted you to be aware of that as we move forward.
Okay, so we're going to go through a couple of case studies I'm going to play Vanna White, and Nanette is going to have all the answers, but we'll go through each of these scenarios to apply what we've learned to some real-life documentation. So the first one is dementia scenarios, and we're going to be talking about Mrs. Smith. She was referred to hospice care for Alzheimer's dementia and a recent decline, including increased confusion from her baseline, combativeness, gait and balance issues, leaving her wheelchair dependent. Miss Smith requires assistance with all ADLs and has stopped eating solid foods, drinks only supplements, and has had a significant weight loss with a BMI at 17. Her medical history indicates a urinary tract infection. She's had a couple of those in the last 3 months, in addition to pneumonia 30 days ago that she just hasn't recovered from. So let's talk about how we'll code this patient.
Okay, thank you, Matt. And I'm going to take some of Matt's wording and help you know that it does take a little bit of science and a little bit of art with the coding. So you have to think about the full patient and what's happening. In this case, and let me just preface this with, all of these diagnoses would have been confirmed with a history and physical or an appropriate clinical document that is signed by a practitioner. So we have information backing this up. So wanted to be clear on that. So we would code the Alzheimer's G30.9. The Alzheimer's code G30.9 requires that we add a code for dementia. FO2.81 will identify the dementia with behavioral. Anorexia. Now I realize the documentation did not clearly say anorexia, but it did say that she is no longer really eating much. And so this is a symptom code that can be assigned by that documentation. She's had weight loss. She has a low BMI. She's had a history of UTIs and pneumonia. And then, of course, we want to kind of cap that off with our encounter for palliative care. And that would be the best way to code this particular scenario to really capture the full picture. Back to you, Matt.
Thanks. It's always nice when they have Alzheimer's disease plastered right on their chart. So next, we'll talk about a traumatic brain injury. So now we're talking about Mrs. Jones, who's a 95-year-old patient with a history of Parkinson's, who was referred to hospice services after a fall at home, resulting in traumatic subarachnoid hemorrhage. She is unresponsive, and her family requested hospice services at the recommendation of the physician. So let's talk about this one.
Okay, in this particular scenario, the traumatic hemorrhage, the traumatic subarachnoid hemorrhage, we're not talking about a late effect of something that occurred 3 years ago, now causing a decrease in cognitive decline or increase in cognitive decline. We're actually talking about an acute traumatic event. That is the diagnosis most contributing to her decline. Again, you've got to think about that wording. So we would code that traumatic hemorrhage, the trauma code, with the loss of consciousness of unspecified duration as a subsequent encounter. In coding, the D code would identify that is an encounter after the patient has gone home. We want to capture the Parkinson's, as we know that would be contributing to the patient's decline significantly. And again, the encounter for palliative care. And then you could add the W code for the fall. This could go before the Z code or after. Most of the time we use W codes after, but there's not anything actually stating that that has to occur. We're just explaining the full picture of what has happened with that patient to cause that trauma.
All right, so we'll talk next about an acute cerebrovascular illness versus a sequelae. So now we're talking about a male patient, Mr. Harper, who's an 85-year-old gentleman, retired teacher, referred to hospice services for acute CVA with dysphagia. He's no longer able to eat and refuses a feeding tube. A swallow evaluation was done at the hospital and revealed oropharyngeal dysphagia. He has a previous history of CVA 2 years ago that left him with right-sided hemiparesis and wheelchair-bound. His medical history does also include hypertension and type 2 diabetes, and he has an out-of-hospital DNR in place.
Okay, we would code this one in this manner, and I know y'all are thinking, wow, they really rarely come that clear. So I want you to know that this information has been gleaned from medical records from live scenarios. So I do understand that struggle. So we could have, in this case, coded the hemiplegia with the right-sided dominant side first if that was the thing most contributing to the decline. However, since the patient refuses a feeding tube and it's more of the dysphagia issue, that's why we should code that primary. So dysphagia following cerebral infarction, again, and according to coding guidelines, you would want to identify the type of dysphagia if known. And in this case, it was the oropharyngeal. Related to a stroke, generally hypertension is considered related to those cardiovascular diseases. So hospice providers in some cases will say, well, the hypertension is not related to the stroke, but that's really untrue. You know, in many cases, hypertension is the cause of the stroke. So we would want to have that as a part of that disease process. And then, of course, showing the decline dependence on wheelchair, the patient does have a DNR, encounter for palliative care, and then we have the type 2 diabetes listed as truly an unrelated diagnosis.
Next, we're going to talk a little bit about hypertension, CKD, and end-stage renal disease. So we'll talk about Miss Thomas, who was referred to hospice services for end-stage renal disease. She is a long-term diabetic, but there is no cause stated as to the reason for the renal failure. She has refused to continue with dialysis and just wants to be at home. Her medical history also includes hypertension.
All right, this is one of the ones, usually with these patients, there's probably a list of another 20 diagnoses that's not on here. So in the essence of time and helping you really understand the main goal here, I've left all of those off. But you have to look at the cause of the renal failure. So there's a couple of things to look at. If in the medical record, the physician states acute renal failure, you certainly could put N17.9 first, and there wouldn't be anything wrong with that. If it's in the medical record and they truly are in the acute phase. However, if the patient comes to you, maybe having been on dialysis for many years and now decides that that is no longer a part of their desire, then it would be more appropriate to code the long-term cause of the renal failure. You cannot code N18.6 ESRD as primary. You will get that claim denied in RTP. But you could look at, and in this case, I will say, the record did not state whether the cause of the renal failure is hypertension or whether it's diabetes. So in this case, we're going to assume it's related to both. So you would code the hypertensive chronic kidney disease, and then the diabetes, and then the renal disease. If, however, in this case, one of those two had been listed as the cause of renal disease, for example, if the record stated that the diabetes was related to the kidney disease, but did not say anything about the hypertension, then we would put the hypertension, we would put the diabetes primary, E11.22, followed by that end-stage renal disease, and then the hypertensive chronic kidney disease would be coded as unrelated as I12.9, I'm sorry, as I10, just regular hypertension, because it's not related to the kidney disease. So those can be a little tricky in that case.
So we'll talk again about hypertensive heart disease and heart failure, very common diagnosis. Miss Anglin was referred to hospice services for acute exacerbation of CHF, or congestive heart failure. Her medical record indicates that she has chronic diastolic heart failure. She has 4+ pitting edema to her lower extremities and abdominal ascites. She requires oxygen continually and becomes short of breath with any activity. Her medical history also includes hypertension. Physician documents end-stage heart failure in the medical record.
Okay, in this case, again, this is one of those ones that's many times coded incorrectly. when you have a documentation of hypertension and you have documentation of heart failure, in the coding guidelines indicate that those are considered related. So the physician does not have to state that the hypertension is related to the heart failure. You would assume that. And in this case, you're going to code that as I11.0, hypertensive heart disease with heart failure. The record also indicates that you want to code the end-stage heart failure and then additional types of heart failure, if known. And in this case, we had acute on chronic diastolic heart failure indicated. So it's not just one code, but actually 3 capturing this. The other ascites is sometimes something that's seen. It's not always common, but does occur in heart failure patients where their fluid will be held in their abdomen. And so that would be something you would want to capture to show the decline. They're also dependent on oxygen. And then again, our palliative care code.
Next, we'll talk about end-stage liver disease. Mr. Hammond is being admitted to hospice services related to his alcoholic liver cirrhosis, which has caused end-stage liver disease. He has ascites, jaundice, weakness, and a poor appetite. Upon assessment, we see and confirmed with the physician that the patient has a stage 2 pressure ulcer to the coccyx.
Okay. So this states a couple of things. This can be confusing. So with your liver failure, when they say that they have liver failure, you're going to see the code K72.90. What is the cause of that liver failure? And in this case, it's the alcoholic cirrhosis of the liver, K70.31. If in fact you do have some other cause of cirrhosis, then you would list that code. And then if it does not say ascites, you can add a code for ascites. Just wanted to make that clarification. But in our patient here, this is how we need to code that. The patient also has a poor appetite, so we're going to code that R63.0, anorexia. And he has a pressure ulcer in the sacral region, listed as a stage 2 in our palliative care code. I want to mention in this scenario, and I apologize, we're going over time, but I don't want to cut us short on our scenarios here because that's the goal is for you to really understand this. You as a clinician, the registered nurse can go out and they can stage the wound, but they cannot state the type of wound. And I know that seems contradictory. So when you're in the home and you see a wound, because many times we're the ones that are going to discover those wounds, or the aide finds it when they're bathing the patient, or whatever the case may be, we determine there's a wound. That must be, the type of wound must be confirmed with the physician in order to code that. And this can be done easily with a verbal order. So if you're getting an order or on your plan of care before that's sent out, you want to be sure that you state that it was a physician confirmed cause of the wound. And that can be a little gray, but I want you to clearly understand that if you're wondering why that coding person didn't add the wound, it may be because there's no physician confirmation. So again, the clinician can stage the wound. If it's a pressure ulcer, if it's a non-pressure chronic ulcer, they can list whether it's the skin level or in the fat tissue. But again, the physician or that practitioner must identify the cause of the wound. All right, back to you, Matt, for our next scenario.
Awesome. Thank you for that clarification. I know wound documentation and skincare is a bit of a gray area for all of us. So primary versus secondary cancers. Mrs. Donovan is referred to hospice services for metastatic breast cancer. She was diagnosed with breast cancer to the right breast 6 years ago and underwent chemotherapy after a mastectomy. She recently went to the ER for a seizure, after which testing revealed metastasis to her brain and bone. She has elected hospice care for symptom management. She is now struggling with pain related to the metastasis as well as nausea.
Okay. Now, as you look at this scenario, some of you are probably thinking, now, wait a minute, you coded a secondary diagnosis primary? So in this case, the breast cancer was something that had occurred multiple years ago. And based on everything that we know in this particular record, that is a resolved condition and a history condition. And the cancer has reoccurred in other locations in the brain and in the bone. So that's why we're going to code those primary. If in fact, though, you had reoccurrence of the primary site, so again, the breast cancer came back, then you would, in that same location, then you would put that primary rather than the history. So just something to keep in mind. Again, we're looking at what is the cause of the current decline of the patient. What is going to cause them to need hospice services and further symptom management? Well, right now, it's the brain cancer and the bone mets. We're also going to be addressing the pain. There is a code G89.3 for neoplasm-related pain and other seizures as were caused by those brain mets. We also have nausea, not related, either no other diagnosis to support that symptom code. So again, we want to list that as how we're managing those symptoms. The patient also had a right mastectomy and had previous chemotherapy, and then our palliative care code. Keep in mind, you know, anti-neoplastic chemotherapy, those chemotherapy can have multiple side effects that end up contributing to the decline of the patient later on, whether it be neuropathy pain, other sites of skin cancer, and other things that you may see for chemotherapy or previous radiation. So it's important to capture that because, again, we're creating the full picture of what's going on with the patient. And that is the goal of coding.
So this is going to be our last scenario. Again, you can see this is a real live scenario here. So we'll go through this this last scenario here. So the summary of the visit with this patient, who's an 81-year-old male living in his own home with his wife. The patient was admitted to hospice with terminal diagnosis of heart disease, comorbidities of anemia, CAD. He had a CABG to 3 coronary arteries, AFib, removal of the infected ICD, so his defibrillator became infected, type 2 diabetes, Parkinson's disease, hypercholesterolemia, COPD, esophageal stenosis, recurrent aspiration pneumonia, and CKD. So quite a laundry list of diagnoses there. The patient's current weight, 158 pounds, BMI of 21.5, the mid upper arm circumference appears blank. The PPS score, a palliative performance scale score of 30%, a New York Heart Association class 4. For ADLs, they have a score of 11 out of 18 with minimal assist for feeding and moderate assist for all of the other activities of daily living. The patient is alert and oriented ×4, very hard of hearing with hearing aids, but he refuses to wear them. The patient seems very well aware of his current situation. Discussion was had with family, and the decision was made to stop all medication except comfort medications and be discharged home with hospice. The patient ambulates with his walker and an assist of 1 to 2 people, uses the wheelchair for longer distances. The patient had a long-standing history of coronary disease, and the device was implanted on May 13th of 2011 and removed on August 8th of 2019 because it became infected. The patient was then admitted to a long-term acute care hospital for IV antibiotic therapy. The patient has failure to thrive. He has a poor appetite and some difficulty swallowing. He is continent of bowel if he can get up and to the restroom in time. Same with urination. He does report feeling tired and weak most days and sleeps on and off during the day, totaling an 18 out of 24 hours of sleep per day. So he has quite a bit going on here. So let's talk about this.
Thank you, Matt. So really, this is a great example of what's happening with the patient. This is, again, a real life scenario of everything that is going on. And don't we wish that it was all lined out that clearly. So this is how you would consider this coded. They mentioned that the patient was admitted to hospice care for heart disease. Again, you want to avoid using that generic heart disease unspecified code because it clearly states that he had a long history of coronary artery disease. So that's going to be our primary code. It didn't list any current chest pain, so we're not going to code it with that. We're just going to code the I-25.10. Contributing to that diagnosis is the atrial fibrillation. He has dysphagia, which is going to contribute to his ability to have good nutrition. And then the R62.7, failure to thrive, the esophageal obstruction. Again, we're looking at functional and structural impairments and what's happening currently with this patient to affect his decline. History of pneumonia, presence of coronary bypass graft, and we've got 2 histories of pneumonia, so we would need to take one of those out of there. Then you've got the palliative care. The patient also has Parkinson's, COPD, diabetes with CKD, and then anemia in CKD, which is an assumed relationship when you have CKD and no other stated cause of anemia. So wrapping this patient up, we really are trying to look at everything that's going on. Now, for many of our heart patients, we would also assume that the COPD could potentially be related, but the record didn't really indicate. He doesn't seem to have a great difficulty breathing. So you have to really discuss this with your IDG, with your medical director, and that's why sometimes determining related or unrelatedness can be a bit gray in that. Same thing with the Parkinson's. If the patient had had some dementia, and that was also contributing to the decline as related to the Parkinson's, then we might be considering that that is a related diagnosis as well. So again, I hope this creates a bigger picture in your mind of how to look at those science of how to code and how to interpret those regulations. I have one little quote for the day before we finish up. And I love this because it says you can have many great ideas in your head, but what makes the difference is the action. So without an action upon an idea, there will be no manifestation, no results, and no rewards. So we really appreciate you attending this segment of our Axxess and Mac Legacy webinar. I ask that you please take 2 things from this and apply it. 15 minutes in your day, one day this week, to apply something to your hospice practice and make it a part of your world.
Nanette, thank you so much. And thank you, Matt, as well, for both of you for sharing your wisdom and your insight during what has really proven to be a challenging and really evolving time for all of us in hospice. And thank you so much for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Stay safe and have a great day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.